Hello, I'm Dr. Ken Landau. Thanks for joining us. We're going to be continuing our discussion of Gastro-Esophageal reflux disease, GERD, heartburn, acid indigestion. We're trying to discuss what the disease is, what causes it, and of course, how we treat it. We already said that the condition is relatively recently described, only in the medical literature. In 1935, a doctor from Mount Sinai Hospital in New York, he described the condition as peptic esophagitis. Well, we know that up until relatively recently, most symptoms in the upper gut were thought to be due to peptic ulcer disease, gastric ulcer and duodenal ulcer. And when those were successfully treated, then we all of a sudden realized that, oh my goodness, a lot of people were having symptoms that we now call heartburn, acid indigestion. Question is, what's causing those problems? Well, first of all, even though most people refer to it as acid indigestion, it doesn't necessarily have anything to do with acid. And as a matter of fact, people who have the condition don't make any more acid than people who don't have the condition. And interestingly, we all have reflux. We all have material from the stomach that at some point in time is going to get into the esophagus, but the overwhelming majority of people don't have any symptoms associated with it. And even the people who have gastroesophageal reflux disease seem to have reflux far more often than they have the development of symptoms. Well, is it a common disorder? You bet it is. 60 million people at least monthly, 15 million people at least daily in the United States. Most of them just reach for an over-the-counter antacid or maybe one of those histamine blockers, drugs like Tagamet or Pepcid, or sometimes now we have the proton pump inhibitors, medicines like omeprazole or Prilosec or Protonex. Those medicines available seem to treat the acid, but maybe don't treat the disorder. Significant number of the people who have the disorder still have symptoms even though they're taking appropriate medications. Well, a couple issues. Number one, is the disorder progressive? Do you go from what most people have, we call it non-erosive reflux disorder. In other words, they don't have any erosions that we can see if we look down the esophagus. So even though they're complaining of symptoms, we can't see that anything is wrong. Well, there's that group of people. That's by far the largest number of people. And then a smaller percentage have erosions. That's the gastroesophageal reflux disease with erosions. And then sometimes the condition can go on and can be associated with complications like strictures and narrowing, so the food can't get from the esophagus into the stomach and then you bring it back up. Or sometimes we have a condition where the lower part of the esophagus, instead of having the normal lining, develops an intestinal type lining. We call that intestinal metaplasia or Barrett's esophagus. And it's thought that that has some sort of role, perhaps, in the genesis of adenocarcinoma of the esophagus. Now, there are two types of carcinoma of the esophagus. We have one, the typical squamous cell. That's the kind of cell that normally coats the esophagus. The esophagus is coated with squamous cells, but in this condition, in Barrett's esophagus, they're coated with, at least the lower portion is coated with cells that are really meant to be in the intestine, not in the esophagus. And then those cells, when they become malignant, we develop what's known as an adenocarcinoma. An adenocarcinoma is rising more rapidly, basically, than any other cancer known to modern science. And the question is there an association with gastroesophageal reflux disorder and carcinoma of the esophagus? Question. So, one, is it a progressive disorder? If you have non-erosive disease, do you have to go to erosive disease and then to some of these others? Or could you have just erosive disorder and for your entire life just have the erosive disorder? And that seems to be the case because we know that once we treat people, they don't necessarily progress. There isn't necessarily the progression to the erosions and then to the strictures or then to the Barrett's esophagus or then to the carcinoma. So it doesn't seem like there's a distinct progression of the symptoms. Now, what's the basic underlying abnormality? Well, we said it's probably not too much acid because we're all producing acid, and we don't all have the symptoms. Well, we know that at the junction of the esophagus and the stomach, that there are certain kind of specialized areas. So at the bottom we have something known as the lower esophageal sphincter. The lower esophageal sphincter is at the junction of the esophagus into the esophagus where it meets the stomach, and it is tonically contracted. That means that under normal circumstances, those sphincter cells keep the junction between the esophagus and the stomach closed. They keep it closed at a pressure somewhere between about 10 and 35 millimeters of mercury. Remember your blood pressure, 120/80 millimeters of mercury. So we know that it's tonically closed. Then we also know that if we look at the diaphragm is the big area that separates the chest from the abdomen, and that muscle that moves up and down and allows us to breathe, well, that muscle also has an opening for the esophagus to go from the chest into the abdomen. Well, the diaphragm circles the esophagus and acts as an external sphincter. Okay, so now we have two mechanisms. We have a third mechanism too. Inside the stomach we have a flap valve, and the flap valve keeps the lower esophageal sphincter inside the chest and the stomach inside the abdomen. And sometimes it doesn't work, and sometimes some of the stomach gets up into the chest either permanently or more frequently intermittently, and that's what we call a hiatal hernia. And all of those things seem to be necessary, all of those areas seem to be necessary to keep us from getting symptoms. So we have the intrinsic abnormalities that may develop, and if we have an abnormality of the lower esophageal sphincter, if we have an abnormality of the flap valve, if we have an abnormality of the diaphragm, then we can certainly get some of the symptoms of gastro-esophageal reflux disorder, but it's more complicated, of course. And we know that if we look at what happens in the stomach after you eat, okay, the food goes down the esophagus, gets into the stomach makes the acid, and now we have the chyme, which is the material, the beverage and the food that you make, that you consume, sits in the stomach, and the stomach makes the acid, and some of the acid mixes, and some of the acid sits on top of this chyme. And when it sits on top of it, it's what we call the acid pocket. And that acid pocket can reflux into the esophagus and cause symptoms. Now, it's important to realize that the mixing isn't always very good, and sometimes the material sits for a while longer than it should in the stomach. But there's a paradox, because we do get some mixing, and you would think that the presence of food ought to neutralize the acid. But typically it's during the time immediately after you eat that you develop the symptoms, which is the least common time you would think on a basis of logic when you would have the symptoms. But no, indeed, that's when you get the symptoms. And then we also know that the stomach has a tendency to relax. And those people who have gastro-esophageal reflux disorder don't have the propulsive waves as great that carry the food away from the junction of the esophagus and the stomach. So we have a longer time when it lags there. And then in addition to all of that, we have another complication. We have a complication where that lower esophageal sphincter that we mentioned, that has to open to allow the food to go from the mouth and esophagus down into the stomach, and otherwise you would think it should be shut. Well, sometimes we have transient relaxations, temporary relaxations that last for maybe 10 seconds to 30 seconds. Well, we have to have some relaxation. So, for instance, when you swallow, the fluid that you swallow has to get down into the stomach, has to get out of the esophagus. So we have to have a transient relaxation for that. But these are relaxations in excess of that, and they last for a longer period of time. And it would appear that this is a dominant mechanism for people who have the symptoms of gastro-esophageal reflux. So it's not that the sphincter is acting abnormally, it's not that the sphincter doesn't have enough pressure, it's just that it seems to relax every once in a while. And these are typically a mechanism where the stomach is going to vent its distension, vent its gas, vent all of the other material, and allow some passage back into the esophagus. But sometimes it happens when it isn't supposed to happen, and when that happens, then you get the symptoms. So what happens when you get some of the acid in the esophagus? Well, you have to be able to clear that out. How do you clear it out? Well, you have peristaltic wave. So remember, the entire intestinal tract is associated with movement of muscle. It's lined with muscle, and the muscle carries the material inside the intestinal tract from the mouth all the way down, and that's how you have your bowel movement. You have these waves of contraction. So when the acid gets back, or the material, whatever the material is, whether it's acid or not acid, gets back from the stomach or from the small intestine into the esophagus, then that stimulates the production of some propulsive peristaltic waves, muscle activity, muscle movement. Well, that's one of the ways that we get material out of the esophagus. And then in another way, we swallow. And when we swallow, we take some of the alkaline material, the bicarbonate, and get that bicarbonate to neutralize the acid. And as a matter of fact, the glands in the esophagus also make material. They make bicarbonate, and that acts to reduce the acidity. So that's another mechanism that we have to counter the whole process. So we have the sphincter mechanism, lower esophageal sphincter, and we have the diaphragm, and we have the flat valve, and then we have the material able to be moved out of the esophagus when it gets there and neutralized by bicarbonate. Now, there's a question: what happens when you lie down? We know that nocturnal heartburn, nocturnal gastroesophageal reflux, relatively common condition. What happens when we don't have gravity? Well, as a matter of fact, because we don't have gravity, we can get some increased symptoms. And we know also that some people don't have very good peristaltic activity. They don't have peristaltic activity that's going to move the material from the stomach at its junction to the esophagus down to where the stomach meets with the small intestine. So sometimes we have some abnormal peristaltic waves there, or we just have some of the material lingering in the stomach for too long. And sometimes we don't have good peristaltic activity getting the food out of, or the material, the acid, out of the esophagus and into the stomach. Well, we know that all of these conditions can lead to symptoms. And then in addition to that, we have obesity, or we have the fat, or we have the bending over, or we have the pregnancy that puts an increased amount of pressure inside the abdomen. And when it does that, now all of a sudden, remember, we have 35 millimeters of mercury max at the junction, so we can theoretically cause some material, either fluid or food or acid or alkaline, to get backward into the esophagus. So lots of reasons for the condition. We just have to, unfortunately, try to figure out which is the most important in any given individual. And now we find that a lot of people have what we call refractory or resistant disease. Now, we don't have a precise definition of what the resistant disease is any more than we have a precise definition of what gastroesophageal reflux disease is. We say that, well, you have the symptoms, you take the medicine is supposed to get rid of the symptoms, but sometimes it doesn't. That's what we call refractive disease. Well, we find that it's interesting because not all people who have symptoms that would typically be associated with gastroesophageal reflux disease have gastroesophageal reflux disease. So you can have symptoms for a variety of conditions unrelated. So we said that there's a differential. Could it be chest pain due to heart disease? Could it be gallbladder disease? Could it be a tumor? Could it be a cancer? Could it be something else? Well, all of those are possible. But then again, we have a heterogeneous group of conditions of people. We have different frequency, different severity. we know that some people who have symptoms will just absolutely not have any significant gastroesophageal reflux disease. We know that some people just have symptoms and they're not associated, even though they're typical. And as a matter of fact, we know that people who have gastroesophageal reflux disease don't have to have any kind of symptoms at all. And we know that some people have the reflux, and the reflux has nothing to do with the timing, because we can measure the acid content of the esophagus. And in some people, we find that there's no association between that reflux and the people's symptoms. And then we know that some people have just a little bit of acid or a little bit of material that gets into the esophagus, and those people just for one reason or another seem to be suffering from some sort of a hypersensitivity. They just have very irritable esophagus. And then sometimes we find people who have gastroesophageal reflux disorder, absolutely typical. They have the reflux is associated with the symptoms, but they're not responsive to the treatment. And then on top of all of that, we have to factor in all of those extra esophageal symptoms. So remember, we were talking about the feeling like something is caught in your throat, the hoarseness, maybe the recurrent ear infections, maybe the asthma or the pulmonary fibrosis. We have to figure out where that sits. But getting back to the main story, it appears that the people who have the hypersensitivity, they're not going to get better with the standard treatment. So for those people, we might have to give them drugs in the antidepressant family, not because they're depressed, but because these drugs alter the sensitivity to pain. And then we have to consider, well, maybe we have to alter the mucosal function. Maybe we have to do something for that. Not sure what to do for some of these people who have atypical symptoms. We're not even sure what to do with people who have the typical symptoms. But getting back to that, we know that non-erosive esophageal disorder is more common in women than it is in men. On the other hand, when we look at the gastroesophageal reflux disorder, especially with the erosions, more common in men than women. Men are fatter than women, and we know that fat's something to do with the whole story. And then the Barrett's esophagus, the thing that sort of sits between normal and cancerous tissue, when we have the abnormal cells inside the esophagus, that's more common in men than women. And as a matter of fact, if we're talking about cancer, much more common in men than in women. Now, what about some of the complications? Well, we know that you can develop a stricture, a narrowing, a scar tissue that can occur in those people who have the erosive disorder. Now remember, women, especially women, have the non-erosive disorder. They are not going to get the complication of stricture. They're not going to get the scar tissue. They're not going to get the blockage between the esophagus and the stomach. Well, we know that as you have an erosion, have an ulcer, as it heals, you get scar tissue, and then the scar tissue can be associated with an abnormality. So when you eat your food, especially if you don't chew it well, maybe you have too big a chunk of steak or meat or something of that nature to get through the narrowed opening. Well, that's a major kind of a problem. And remember, food impaction by itself is not a symptom of the gastroesophageal reflux. It's a complication-associated condition. And those people who have the strictures, we're going to have to treat them differently. We want to keep the acid production to a minimum, of course, so we give them the antacids. But these are the people who need the proton pump inhibitors, the more potent drugs. They're the ones who need the Prilosec or the omeprazole. And those are the people who may well have to have a tube inserted to open up or to expand the area. We also have this condition called Barrett's esophagus. Now, we have to talk about Barrett's esophagus because that's a very peculiar condition, and it's a condition that's caused a lot of anxiety and still causes a major problem because not all doctors treat the condition the same way. Now, you have to realize that this Barrett's esophagus, and Barrett's esophagus is the presence of cells that normally line the intestine, but instead of being in the intestine, they're in the esophagus. That's what Barrett's esophagus is. And the question is Barrett's esophagus precancerous? And that's a major issue, because in many people, Barrett's esophagus is absolutely, unequivocally harmless. But unfortunately, in a small number of people, the Barrett's esophagus may progress. Can we identify who it's going to progress in so that we can do something? Well, once upon a time, not terribly long ago, people who had Barrett's esophagus were treated with removal of the esophagus. That obviously is inappropriate. So the definition of Barrett's esophagus, we don't really know for sure, but over the period of the past 40 years, we know that there's been an increase in the incidence of Barrett's esophagus associated with a dramatic increase in the association with cancer of the esophagus. And we know that men are at least 3 or 4 or 5 times more likely to develop Barrett's esophagus than women. We know that the condition is almost always in Caucasian males. We know that it tends not to affect African Americans, tends not to affect Asians, tends not to affect children, although it may develop in those children who have gastroesophageal reflux disease as children or infants about 30 years later. We know it's more common in people who smoke cigarettes, and we also know that Barrett's esophagus is a condition that may run in families. Well, we also know that the elderly who have been going for years without maintenance therapy, they can seem to develop the condition. And we know that the people who have more severe erosive esophagitis seem to be associated with a greater incidence of Barrett's esophagus. So we know the basics that seem to be associated with it, probably cause and effect, but we're not sure. And we know, by the way, people who are heavier, people who are fatter, people who have the fat centralized around the mid-abdomen seem to be at greater risk. So Barrett's esophagus, especially in people who are overweight, people who are over age 50, people who've had the symptoms of gastroesophageal disorder for at least 5 or 10 years, people who have some sort of abnormal motility. Now, here's the kicker. If we look at people who have the endoscope examination, people where the doctor puts the endoscope, the tube, down from the mouth into the esophagus and looks around, we find that somewhere around maybe 10 or 15% are going to have Barrett's esophagus, which is a horrendous number, a gigantic number. And we already said that it tends to occur in older men. But now here's another kicker. Well, in about 25% of the people, they're going to be less than 50 and they're going to be women. The likelihood of Barrett's degenerating into cancer? Well, if we look overall, somewhere around 0.1, 0.2, 0.3% per year. Now you have to realize this condition is associated with abnormal cells lining the esophagus. And those cells that are lining the esophagus are columnar. They are not the typical squamous cells. And it seems that the columnar cells in the wrong location might predispose to cancer. Well, how did they get there in the first place? Well, we don't know. There are several ideas about how they get there. One is the thought that they're just the regular squamous cells in the esophagus, but somehow they make a change, what we call transdifferentiation, and they go from the squamous cells to the columnar cells. So that's one way. Another way is what we call the transcommitment. And what that is the cells are the immature epithelial cells, and they're progenitor cells, and they just go the wrong way. And we know from rat experiments and we know from mice experiments that maybe it has to do with some cells that come from the stomach and migrate upward. Maybe these cells are the immature cells, and maybe the cells are stem cells from the marrow, and that they get into the esophagus and they make the wrong kind of cells. Well, all of that is possible. So we know that the Barrett's is typically just associated just above the esophageal gastric junction. And we know those are the cells that seem to be abnormal. Now, biopsies can be taken, but unfortunately, the biopsies might just show the columnar cells, the cells that aren't supposed to be there. They might not show, because the abnormality, the abnormal cells, the cells that seem to degenerate, The cells that seem to go on to progress maybe to cancer, the cells that have abnormal DNA, they're not uniform, so they're patchy, so biopsies might miss it. We know when we look at the esophagus, typically the squamous mucosa is going to be a pale color, and it has a glassy appearance as opposed to the Barrett's that tends to be salmon color, red color, and it seems to be relatively coarse. Now, making matters even worse, we have another complication. We have what's known as Barrett's esophagus, either a short segment or a long segment. Short segment defined as less than 3 centimeters in length, long segment more than 3 centimeters in length. Well, it seems that the short segment Barrett's is unassociated with progression to cancer. It seems to be an endoscopic finding that's just one of those things. The long segment seems to be associated with the severe gastroesophageal reflux disease, the erosive esophagitis, and that's the kind that may progress to other problems. Now, we know that if we look at the definition of Barrett's esophagus in the United States versus, say, in Britain, there is a little bit of a distinction on how we make the diagnosis. In the United States, we need not only the intestinal metaplasia, you know, some of those cells from the intestine getting into the stomach, but then we need the presence of goblet cells. Over in Europe, they don't think those goblet cells are necessary. The problem is that it's difficult to see the goblet cells, impossible to see the goblet cells, because they're underneath the lining. And as a result, we don't see them. And it seems that sometimes when we destroy the lining with our therapies, those cells can either get killed or they can come back. So in therapy, we need to eradicate all of the tissue. And that's why once upon a time it was thought that you had to do major surgery. Well, we know that if we look at some of the cells associated with Barrett's, we can tell which ones are more abnormal, which ones are less abnormal. So the more abnormal cells have abnormalities of the genes. So we talk about the P53 being abnormal, and we have altered DNA content, and we have some problems associated with the epigenetics and the DNA methylation. And all of that's important because that gives us an idea who's more at risk for cancer and who's not more at risk. So overall, as I said, the risk of developing cancer from Barrett's esophagus is somewhere maybe 0.1% to 0.3% per year. Of course, the long segment more than the short segment. More of the cancer in the familial form. And then that brings up the question is, should people be screened for Barrett's, especially if Barrett's is so common, 5 to 15% of normal endoscopic examinations revealing Barrett's esophagus. That's why we have to devote some time to discussing this particular issue. And the answer is it's thought that for some reason, something has happened relatively recently to cause Barrett's esophagus. Maybe it's a change in diet, maybe it's a change in products that we consume and we're not exactly sure what they are. Maybe it's exposure to some sort of virus, maybe it's some bacterial exposure, just don't know the answer. But it seems that more recently the incidence of Barrett's has been increasing, and we think it's a cohort effect. So, do we screen? And the answer is probably it's not a good idea to screen for the presence of Barrett's esophagus in those people who have the routine, ordinary, run-of-the-mill Gastro-Esophageal disorder. Now, if people have erosive disorder, if we do an examination with that tube and we find that there are erosions in the esophagus, we should probably screen those people after therapy, give the people the therapy with the medicines like the omeprazole or the Prilosec. We give the people the therapy, evaluate them 8 weeks later, 2 months later, they should be better, the erosion should be healed. If there's no evidence of Barrett's esophagus, if there's no evidence of any significant abnormality, that's it. They don't have to screen anymore. The American Gastrointestinal Association says maybe you screen every 3 to 5 years if there's no evidence of dysplasia. If there's minor evidence of dysplasia, a little bit of dysplasia, not severe, but just a little bit, well, maybe you screen those people every 6 months. If there's severe dysplasia, maybe you screen them every 3 months. But the problem with the screening is that it's expensive, it's associated with some finite number of complications. We often treat people for serious diseases when they don't have any serious disease. We cause lots of psychological stress, and as you can imagine, we reduce the quality of life. Now, previously, if people had high-grade dysplasia, they were treated by removal of the esophagus, a horrible procedure associated with lots of complications, and for the overwhelming majority of people, not necessary. But we do know that if you get cancer of the esophagus, and it's just on the surface, well, less than 2% of those people are going to spread to the lymph nodes. On the other hand, if the cancer is a little bit deeper, if it's in the submucosa, if it's underneath the surface, then you have about a 1 in 5 chance or greater that it's going to spread. And if it spreads to the lymph nodes, well, we know that the prognosis of esophageal cancer is very poor at the present time. Now, how do we treat significant Barrett's dysplasia, the complication, theoretically, of gastroesophageal reflux? Well, now we can treat the disorder with diathermy, with some photochemical techniques, now with some radiofrequency ablation, and the treatment seems to be a lot less invasive and a significant improvement from what it was. Now, why do we try to do all of that? Because of our fear of esophageal adenocarcinoma. Remember, we said esophageal carcinoma is 2 groups. Squamous cell carcinoma, the traditional type of cancer of the esophagus. The esophagus is lined with squamous cells, so when those squamous cells become cancerous, we get a squamous cell carcinoma of the esophagus. But now, with Barrett's esophagus, with what's thought to be a complication of gastroesophageal reflux disorder, we get the columnar cells, we call that metaplasia. So instead of the squamous cells, we have cells that typically line the stomach and small intestine. And those cells in the esophagus, when they get to be cancerous, they cause an adenocarcinoma. Overall, there are about 18,000 people going to develop cancer of the esophagus in any given year here in the United States. We know that up until recently, most of those cases were the squamous cell carcinoma, but now with Barrett's esophagus, we know that the majority of these cases are now thought to be as a result of the adenocarcinoma caused in part by Barrett's esophagus. Well, that's a significant increase over the period of the past several years. So, now, to make matters even more confusing, as if they weren't bad enough already, 40% of the people who have the adenocarcinoma of the esophagus have never had any history of gastroesophageal reflux disorder. And as a matter of fact, fewer than 10% of the people who have the esophageal cancer have a history of Barrett's esophagus. So we know that it's a very complicated story, and we think that it's associated perhaps with virus, perhaps with infection, perhaps with some other kind of factor other than what we would expect, other than the standard gastroesophageal reflux. So although those 2 conditions, gastroesophageal reflux and Barrett's esophagus or cancer of the esophagus, are associated, we don't know that there really is an association. And now, for a moment, let's just talk about nocturnal symptoms. So most people think, well, look, the condition follows eating. I eat and then I get the symptoms. Well, that's true. You eat and then you get the symptoms, but symptoms don't have to come just in the daytime. As a matter of fact, we know that nocturnal gastroesophageal reflux symptoms bad enough so they wake you up in the middle of the night, are very common. Well, if you make the acid when there's food in your stomach, and then if you go to bed several hours later, and then maybe several hours after you go to bed, you have acid. Where's the acid coming from? Well, as a matter of fact, we know that the stomach has a relatively low pH. And we know that probably 70% of the people are going to have at least an hour where the pH in the stomach is going to be less than 4 in the course of the night. That's either with or without therapy. So normal people who don't have anything wrong with them are going to have that. So it's not a sign that the drugs aren't working. But if the pH is less than 1, then we have a problem where you're not getting appropriate therapy. Well, how common is nocturnal reflux? Nocturnal reflux is extraordinarily common. If we look at 1,000 people who have reflux at least once a week, we find that 80% of them are going to have some nighttime symptoms. And as a matter of fact, in 60% of them, it's going to interfere with their quality of life or their ability to sleep. And somewhere in 40% of them, it's going to change their activities on the next day. So significant. And we know that about 50% of the people who have nocturnal symptoms are dissatisfied with the control of their disorder. Now, if we talk about erosive esophagitis, the presence of an erosion inside the esophagus. And remember, when we're talking about gastro-esophageal reflux disease, especially in women, most women have non-erosive reflux disease. They don't have any erosions. They just have the symptoms. Men, on the other hand, are more likely to have erosions inside the lining. And if you have an erosion inside the lining, then you have probably an 800% increase in the likelihood of developing that esophageal adenocarcinoma that we talked about a moment ago. And if you have very frequent nocturnal symptoms, then chances are you're going to have maybe 1,000% increase in the likelihood of problems. And that brings us up to what do we do for the symptoms of nocturnal disease. So if you have nocturnal disease, we like to treat you with a lot of those proton pump inhibitors. Medicines like Nexium and Prilosec, medicines like omeprazole. Those are the medicines that we use. But sometimes they're not sufficient by themselves. So now there's the tendency not only to give 2 pills of the standard PPIs a day. Typically, the treatment is just 1 pill a day, but now we give 2 pills a day for those people who have nocturnal symptoms. And then on top of it, we use a medicine like Tagamet or Prevacid in the immediate bedtime frame so that hopefully we're going to be able to treat the nocturnal symptoms. Well, how do we work people who have symptoms? How do we evaluate them? And then, of course, how do we treat them? We're going to tell you that next week. Thanks for watching. I'm Dr. Ken Landa.